Good afternoon, everybody. So, we're spread all the way across the stage, which is great. Well, or everyone just come over here. It'd be easier for me to talk to you all if you all just come over here. Have we got enough space for everybody? Okay. Right, so we're going to be talking about some more osteotomy concepts. We're really just going to go through a number of cases. Now, I'll give my apologies to start with in that I didn't hear a lot of the talks this morning because we were in the OR, so there may be some overlapping concepts. I hope I don't say something, or we don't talk about something that's completely off pat. But anyway, even if we're talking about the same things, repetition is never a bad thing, particularly when we're trying to get into these maybe sometimes more challenging concepts. So before I start though, I mean, huge influence on me and many of us here in regards to osteotomy was this guy, Dr. Peter Fowler. And Pete sadly passed away just at the end of 2022. And he was a huge influence in the world of osteotomy in North America and internationally. And of course, he is greatly missed. So, first case. We'll start with Brett, but I'll just run you through this, Brett. So, 43-year-old female. She's bilateral mild varus alignment. She's got very good quads, tone and bulk. She's got some medial joint line tenderness. I don't know if yet. So she's actually a spin class instructor. She's very fit and active, and she really is not in any way interested in any form of joint replacement, in case anybody would be thinking about that. Okay, nor should she be indeed. Okay, and she wants to get back to her level of activity as quickly as possible. Okay, so you can see her radiographs there, and so then we've got her alignment films. Now I've just drawn the Mikulicz line. I haven't given you any of the other values. Anything there, when you just eyeball that, any concerns? And you know, I think Christian touched on it earlier on today when talking about whether or not the deformities in the femur, should we be doing a tibial-based osteotomy or a femoral-based osteotomy? What's your approach in these cases?
Yeah, I think you need to measure up all the angles and things, but just looking at it, other than the fact I'm sitting on a stage waiting for a trick, it looks like a pretty straightforward case of moderate medial OA. It's not going to be a big correction. You could possibly think about doing it wherever your preference is, if the correction's not terribly big. My general correction is most of the deformity I see is around the tibia, so just a medial opening wedge HTO, but I'd measure the numbers.
Andy, any?
Yeah, I'm a bit obsessed about leg length, and I tried to make that point yesterday. I'm not sure Christian understood the question, but I've seen a number of very angry patients who've had a medial opening wedge osteotomy on a long limb, and then they feel the difference. And unfortunately, because it's an easier operation, and particularly in our society where the osteotomy art has been lost, we can't do closing wedge osteotomies anymore. Everyone does opening wedge. So you need to really think about leg length, and if it's a short limb, do opening wedge. If it's a long limb, do a closing wedge. And the other thing is to respect the fact that any femoral osteotomy only affects the early flexion arc, whereas a tibial osteotomy affects the whole flexion arc. So for skiing, for horse riding, for cycling, it's great to have a tibial osteotomy because it's going to correct all the way through range.
Fantastic. So this was actually before I started doing regular deformity analysis. I didn't have the appropriate software at the time. But Dinshaw, with every case, you're in clinic, you've got a busy clinic, I'm sure your clinics are crazy. Every single case, are you going through a full deformity analysis with every single HTO or potential osteotomy correction, should I say?
So I think my first step here would be to try and find where that pain's coming from. So it's medial knee pain, it could be just malalignment, it could be an intra-articular cause like a meniscus or a small chondral defect, something that's easier to treat. So if my clinical evaluation seemed to suggest that there was something intra-articular, there's an effusion there, I'm going to get an MRI done and see, is there something that I can treat easily, arthroscopically, than making her undergo anything more extensive like an osteotomy.
So if I show you those, you look at those Rosenberg views, I mean, is really as an MRI indicated in this scenario?
I would get it.
Brett?
Yeah, I mean, on the face of it, it may not change what you're going to do unless you see something dramatic on the lateral side. I always get one, but I don't know if it's going to change a great deal here.
Tranjit?
I will get an MRI to see how the lateral compartment. My thoughts are the same. It looks like a medial osteotomy, open wedge. I'm a bit concerned with some osteophytes under the patella because we know with medial wedge open osteotomy you can cause a bit patella baja, and whether that's going to. She has some symptoms under the kneecap, but I will get an MRI to see the lateral compartment.
Okay, well, so I don't get an MRI routinely because I really, with that degree of osteoarthritis, it's a public healthcare system, so we really try and limit the amount of imaging that we would get. So I'll just tell you what the plan was. This was a bilateral HTO, angular stable locking plate. It was a small correction of 6 millimeters. Early weight bearing, unrestricted return to full sport. This was our arthroscopic findings, so great opportunity to get in relatively early. Rehabilitation, touch weight bearing for 2 weeks, and then weight bearing is tolerated thereafter. 6 weeks post-op, she taught her first spin class. So she was back to her activity level pretty quickly. And 1 year post-op, took the plate out and did the other side. So let's start with Bushnan. When you do it with an osteotomy gap of 6 millimeters, do you fill it with anything?
No, so till 10 millimeters, I'm absolutely fine. It's been shown even 20 millimeters is fine, but we being a slightly conservative group, I normally graft about 10 millimeters.
And what do you use to graft?
I use allograft.
Allograft, okay. Anybody else do something differently? Andy?
So I don't graft until it's 15 degrees, but then I use autograft.
Okay.
If it's 6, I'm not going to graft it. But usually I don't get a correction of 6. So usually most of my corrections would be 7, 10. And for those, I get allograft bone very easily. I just pack it in there. It's not really for union, but it's more like a plug. It just prevents the bone from oozing. And I think your post-op is much better if you've packed it in there.
Do you not worry that allograft slows down healing, bridging? I don't know.
I don't think so, because the study that was done, I think ESCA did that study where they did HA blocks there, leaving it alone and putting allograft. And the HA blocks were, of course, contraindicated now. That's the worst.
Yeah.
But there were some patients that did land up with delayed union if you didn't put in graft. So I think putting in an allograft is not too much of a problem.
You've got a choice between particle allograft or a structural allograft. And you're just using the little bits, packing them in.
Just packing in the little bits.
Yeah, we just use chips, and I agree with Dinshaw, actually, just really creating more of a hemostatic effect. A lot of the pain with osteotomy comes from a periostitis with the bleeding on the periosteum. Clement, do you have any technique that you would use to protect the lateral hinge?
No, for small corrections up to 7, I don't use a hinge K-wire. Any larger corrections, I'll use a hinge wire, but I don't use a screw, like how Bhushan used.
So I'm going to come back to you then, Bhushan. So what is your indication for using that screw?
It initially started just as a sort of something I picked up from Christian and his team about putting a hinge pin. And then a couple of paces, they put a Howard screw on the lateral side. The whole purpose of doing this to allow early weight bearing without compromising your hinge stability. Of course, the angle stable plate in which you are able to compress the hinge, supposedly secure your patient against a collapse or against a translation. But as I was telling you before, I had a couple of patients who had lateral knee pain when they started weight bearing, even with a Tomofix plate. And when I really looked properly at the X-ray, there was a hinge propagation, crack propagation to the lateral cortex, Takeuchi type 1. So type 2, which is not that bad. But because of pain, the weight bearing got delayed by about 6 weeks. They were slightly grumpy. On the X-rays, you could see lateral callus formation. So it was a proper hinge. And since this is about 2 years back, and since then I started putting a hinge screw. And touch wood, I haven't had a single episode of any patient complaining of lateral knee pain. It's, as you saw in the surgery, it takes about 5 minutes, and it really gives you a nice, secure feeling.
Maybe a show of hands from the panel then. Let's say we had a 10 millimeter correction, medial opening wedge. How many of you are routinely putting in a hinge screw? Okay, so I mean, it's an interesting technique, and certainly it's not something that I've been doing routinely, but it's certainly something I would think about. Brett?
So what I'd say, I know the question's aimed at a specific thing like a hinge wire or a hinge a screw, but there's many steps to protecting the hinge.
Yep.
I think you get the osteotomy in the right location to start with, both proximal, distal and medial lateral. Make sure you complete the osteotomy, tapping across the back. I put my finger across the back of the osteotomy, just feel the very tip of the osteotome. So I know it's through cortex. Sufficient release of the MCL. And the bigger the correction, the more you need all your ducks in a row.
Yeah.
With a small correction, you can get away with a lot more. But there's the multiple steps. And the last bit that I see lots of people do that I've always had an issue with is the way you open the osteotomy. So you've got the wedges that you tap in to spread it open. That's how a stonemason splits big blocks of stone. It's how I used to chop wood on the farm. You get a blockbuster and drive it in, and it splits it apart, because as you drive it in, it gives a distraction, not just an opening. So I'm a big fan of using a spreading osteotome just a lamina spreader to make sure I'm hinging it and getting the plastic deformation, not tapping in one of those wedges.
Yeah, I think it's very important that I showed in the surgery is not to put, when you're using those stacked osteotomes, is not bring them all to the same point.
Yeah.
Because as you get to the same point, you're going to have
Spread
that
apart.
problem.
But is that triangle wedge that is
Yeah.
often used in that? I don't like that one.
Dinshaw?
So I use stacked osteotomes as against the laminar spreader primarily, because if you've got a slightly osteopenic patient and you could get a type 3, an intra-articular extension with that. So I typically like the stacked osteotomes. I think that's a slow, steady sort of, opening that you get, and then you take it out, and then when you put your laminar spreader in, I think that's a safe
I do
way.
the same thing. The stacked osteotomes, they were acting as a lever. They're not acting as a driving wedge, as Al just said, the way you drive it in.
So, Brett, I'm going to come to you now. So, we're going to see you and Dave doing this case later on. Are you routinely using PSI in every single case now, or are you using them for more special corrections?
No, we're using it for everything now. So for a long time, we used navigation.
Yep.
And then when we developed our version of the PSI, we validated about 80 cases against the nav. And that was a very tight correlation for both the wedge height and the correction. So then we stopped using the nav. So we use the PSI on every case. I do add nav in really tricky, complex cases on top of that, but PSI is my standard.
So I'd love to get an understanding from the audience. So maybe if everybody could raise their hands who use osteotomy as a regular part of their knee practice. Show of hands. Okay, and if you could keep your hands up if you've used PSI. Okay, so really quite small. So you have used PSI. And are you using it on a routine basis or just for?
Yeah, I've stopped using it, and obviously I don't use the same as Brett. The biggest problem is fitting it correctly to the bone, and it wasn't too bad because I realised that it perhaps wasn't putting me in the right place. I corrected it, but I did 2 or 3 cases and stopped. One of my colleagues recently did a distal femoral osteotomy that's been a disaster because he went along with the guide and it just was not right, so I had to revise it, and the patient's now suing him. Actually, it's not good. So you plan it on imaging like this when there's no soft tissue, it looks great, or on sawbones. But I think it needs refining, and certainly I know a little bit about the Sydney technique, and it does seem to be better.
Yeah, so I think it's really evolving technology, and I've used it a few times, and I'm quite excited by it, and it'll be interesting to see whether or not that becomes mainstream practice or just niche parts of the world. So let's talk about actually managing our patients. Charanjit, so perioperative analgesia, what techniques do you use to try and actually look after your patient? Because this can be a painful operation, right?
Yeah, it's operation of the bone, but surprisingly, they're not as painful as we think it is. And quite a number of the time, anesthetists decide to do it under spinal and manage to post-op pain with some opiates and non-steroidals. They do fairly well.
So spinal, Bhushan, any blocking? Any blocks, femoral nerve blocks, adductor canal?
It's spinal with some sedation, then followed by post-op pain relief with oral and IV as necessary.
Okay.
I use the same cocktail that we use for TKRs. I just inject around the osteotomy, mainly posteriorly. It works quite well in most patients.
Your cocktail? You don't need.
So just standard. So bupivacaine, 0.5% bupivacaine with some adrenaline, along with 1 gram of tranexamic acid, and just add some holy water, some antibiotic to it as well.
Okay. You all using TXA? Everyone's using tranexamic acid?
I think tranexamic acid has been a game changer for major surgery, actually.
Yeah. Clement, you use tranexamic?
Yeah, I use spinal analgesia along with femoral nerve block.
Okay.
But it's very important to monitor the neurovascular status following this procedure. Sometimes they may develop a compartment syndrome or an occult vascular injury. Just now I was discussing with Ranjit. So if you have a very solid pain relief also, we may miss the early symptoms of vascular compromise. So I make sure that The vascular monitoring takes place, and usually these patients are observed for neurovascular status for at least 24 hours, and they are discharged after 48 hours.
Great. Now, in North America, we have a massive issue with narcotic medication, and there's this opioid crisis. So there's a real push to try and have less patients on opiate medication. What do we think about using non-steroidals in an opening wedge osteotomy? Brett?
Yeah, I avoid it. I'm not aware of any literature in the human literature, but the animal studies suggest some delayed union. We don't have the opioid crisis, so I'm still allowed to prescribe it. So I don't use anti-inflammatories, but you certainly notice the difference. The ones not using an anti-inflammatory have a lot more pain, but I try and avoid it.
Andy?
It's interesting with the opiates. I mean, obviously we were all worried it would happen with us in the UK, but I think the doctors in the States have to take a big responsibility about prescribing habits. I mean, we give a maximum of 5 days OxyContin. It's a fantastic drug with Oxynorm, which is a fast-acting for breakthrough, and we will not repeat the prescription. I saw a guy who had an arthroscopy in California. He was given 30 days of OxyContin, and we would never give that out. So no wonder they got a problem. But anti-inflammatories, they're in pain. Anti-inflammatories really work for bone pain. So early on, I'm not worried, but I do encourage them to get off them, and regular paracetamol after a few days works.
Dinshaw, are you doing these as day case or inpatient?
They stay overnight.
Yep.
So for pain relief, they get a femoral nerve block. They get some local infiltration of local anesthesia. They do get a patient-controlled PCA, and that will have fentanyl in it. So that's overnight PCA. The next day, they'd get on to non-steroidals, which would be for 4 days. Typically, in about 4 or 5 days, these patients don't require any further medication.
Yeah. So it's interesting for us. I mean, so much of our surgery, particularly in COVID, really changed this, is really pushing day case surgery. And when you're dealing with big cases, sending them home day of surgery, you need to send them home with some opiate medication. So you guys are probably doing a lot of your opiates as inpatients and then going home with different medications. So anyway, these are real world issues. And then with this girl, if we go back to 6mm correction, weight-bearing status, run down the line very quickly, Brett.
Yeah, I do 4 weeks of 50% weight bearing, followed by full weight bearing.
Andy?
You've got to make sure the hinge is intact.
Yep.
As long as it is, I've got no restrictions.
So 2-week x-rays are looking good. Dinshaw?
So exactly the same as Brett. I usually keep them protected for about 4 weeks or so.
Tranjit?
Same, partial weight first and then full weight after that.
No, weight bearing is started from day 1, day 2.
Okay, and that, do you feel you can do that because of that screw that you're putting in?
I was doing that before as well.
Okay.
But I'm just more confident of doing it now.
Clement?
Partial weight bearing for 4 weeks.
Okay.
I think the truth is the patients don't fully weight bear. Even you tell them not to worry about it, but because it's sore, they don't fully weight bear.
Okay, so next case. So I've got quite a few cases to get through here. It'll be a miracle if we get through them all, but that'll be fine. Okay, so 29-year-old medical student. He was actually my master's student for a period of time, and went to medical school afterwards. So subtotal lateral meniscectomy, 10 years when he was playing university American football, Canadian football. So complains of persistent lateral knee pain, worse than weight bearing, but also at rest. He has some mechanical symptoms, but no locking, no instability. He's otherwise healthy. He's a big guy, 6'4" tall, 230 pounds, asymmetric valgus. He's got symmetrical quads, tone and bulk, dry, stable knee with what I describe as a positive pivot grind. So I do a pivot shift, and it's really, whilst I'm not eliciting ACL anterolateral rotatory laxity, he has pain and sometimes crepitus. And actually you often pick that up even if with a root tear. So it's a really nice test if you really want to load the lateral compartment. So here's his radiographs. You can see he's got some early degenerative changes laterally. His Rosenberg view is certainly collapsing down in the lateral side. And lateral view pretty reasonable, no significant patellofemoral changes. So this seems to be isolated lateral disease. Andy, you want to make a comment?
Yeah, no, there's a really, medial OA is anteromedial, it's an extension disease, whereas lateral OA affects the posterior part of the femur, and so it's a flexion disease. And our only measurement we have is long leg alignment films in extension. So how the hell would we work out what to do? You'll tell us.
Okay, so well, as you've said it, this was his arthroscopy, and there's his alignment film. Okay, so you can see his Mikulicz line. He's got asymmetric valgus alignment. What do you do? Andy?
So, as I mentioned, he's obviously got damage on his tibia, and the damage on the femur will be predominantly posterior. It's a flexion disease. If you do a femoral osteotomy, in most of these cases, you preserve the joint line, but you only correct in extension. So I love doing tibial osteotomies, but you've got to be very, very careful not to overly deform the joint line. I used to be a bit of a cavalier about it, and I've had my fingers burnt. I've had 2 patients, so I created quite significant joint line obliquity. One was 10 degrees, one was 8 degrees. The femur slides downhill, according to the work we did at Imperial College, and these 2 patients both had a posterior root avulsion medial meniscus, and it was a disaster. I've had to revise both osteotomies and straighten them up.
Okay, so so you're going to do a tibial correction. Do you do a medial close or a lateral opening?
My strong preference is medial closing. It's very easy, bone on bone, it heals rapidly. And also you haven't got the tethering effect of the tib-fib joint if you do a lateral opening.
Then, Shaw, with those numbers, would you agree to do a tibial correction, or do you think a femoral correction is a better option here?
His MLDFA is 89. It would be a tibial correction, but it's going to be a relatively small correction.
Definitely a small correction. So originally, you know, the dogmatic approach that initially thought, oh, it's got to be a distal femoral osteotomy, right? But actually then, deformity analysis, you have a look, you can see a lot of the disease, as Andy says, is inflection, it's tibial based, and sure enough, we actually looked at the deformity, it's more in the tibia, so we ultimately did.
These are the more difficult ones because these are closing wedge.
Yeah.
And they're small corrections, and you've got a blade that's 1 millimeter and 1 millimeter, and there's got a little bit of play there. So I'm always a little apprehensive of these. So if I'm doing a PSI, this would be really the indication for a PSI.
Okay.
And we don't do too many PSIs, but if there's one specific indication, is this. I think on the femoral part, as you were mentioning, that the PSI jig is just too large.
Yeah.
And I think that's a concern. But for the tibia, I think that's not a concern. Yeah.
Perfect. So I just really wanted to show that case, just to demonstrate not all the time we're going to be correcting on the femur.
And the people who have a tibial osteotomy for lateral OA love it. They absolutely love it.
Okay, so Clement, case 3, this is a pretty complicated one. So this is a case that I treated in Abu Dhabi. So multiple ACL reconstructions in the past, including partial medial meniscectomy, had a failed hamstring tendon. He then had an allograft bone grafting, had open revision using a BTB autograft in 2011, further non-contact injury, and he comes back now with ongoing instability. This is the case I did with Charlie Brown. You can see Charlie doing the examination under anesthetic here. Okay, so he's got an element of fixed flexion compared to the other side. He's got significant anterior laxity. He's got positive anterior drawer. Big pivot shift. So significant anterolateral rotatory laxity. I think you can see that. Okay, and no significant coronal plane issues. So these are his radiographs. So clearly some previous hardware, some old tunnels there. Okay. And I'm just going to show you all the imaging, and then we'll just summarize the problems, and then we'll get your thoughts on what you might do. So his weight-bearing alignment films there, he's in neutral alignment. Okay, his monopodal weight-bearing lateral view. He's got increased posterior tibial slope. Now, interestingly, we've measured that off a long leg film, 17 degrees. I'll say that I've said this before, but remember, most of the measurements where we've looked at 12 degrees as being the risk factor for an ACL rupture are based off short films, and they're based off the medial plateau. So if you take a measurement on the lateral plateau and you do it on a long film and you still use 12 degrees as your cutoff, you're going to be doing a lot more anterior closing wedges than maybe you should be. So just something to think about, food for thought. Okay, anterior translation, he's got 8 millimeters of anterior translation. So, bit of a problem. His MRI demonstrates medial meniscus deficiency. His graft is non-functional. Collaterals are intact. Tunnels aren't looking too bad. So problem list, he's had 2 failed ACLs, medial meniscus deficiencies, a lateral meniscus posterior root tear, increased posterior tibial slope with associated increased anterior tibial translation. So there's a lot of stuff going on in this knee. Clement, what are the important things that you're thinking about with this patient? He's complaining of medial pain plus instability, and it's the instability is his major problem.
In this case, his main problem appears to be the instability. And also he's got an osteoarthritis, which is going to compromise any ligament reconstruction in this particular patient. And primarily, the alignment looks good. Probably what I will do is I will correct using a brace trial to see if unloading the medial compartment improves his pain. So in that case, we can consider a slight valgization along with the revision ACL. And
so his alignment essentially, his coronal plane alignment is sitting on his lateral tibial spine.
Okay.
Probably don't have an awful lot of room to be doing a coronal plane correction here.
Okay.
There was no focal chondral damage, was there?
No.
Just one question.
Sure.
What's his extension? Does he have any hyperextension?
He's got a fixed flexion deformity compared to the other side. So why do you ask that question, and why is it important?
So for me, I mean, getting his slope now from 17 and bring it maybe to 5 is a good option to give him stability. If he's got a flexion deformity, that would be the ideal case to do this, because if they've got hyperextension and he goes into further hyperextension, it's going to be a problem. So for me, this would be a two-stage procedure. So in the first stage, all I'm going to do is a corrective osteotomy, anterior closing wedge, get his slope to 5 degrees, graft the tunnel at the same time, and clear it up from implants and all the rest. Do whatever cleanup you need to do. If that gives him enough stability, because I am going to keep him on some sort of activity modification subsequently. If his instability is more with running, etc., now his pain's going to go, hopefully his instability is going to be better. If he comes back to me with instability, then I'm going to consider revision ACL.
Why do you think he's got pain, Al?
Meniscus deficiency.
Yeah.
And bear in mind, with meniscus deficiency, although his alignment is neutral, he's still loading preferentially on the medial side because the center of his mass is still creating an adduction moment. But I'm going to ask you, Andy, you've published that pretty much all of your revision ACLs are done in a one stage.
Yep.
So are you going to stick to your guns and do a one stage revision here?
Well, I need to see a CT scan.
Cop-out. That's a cop-out.
I think far too many two stages are done. You can see the femoral tunnel looks like it's nowhere where it should be.
Yeah.
For presumably the first ACL, the second one probably better. The tibial tunnel, actually, I'm not overly worried about that. So I suspect I'll do it in one stage. And particularly with a closing wedge osteotomy, you use staples, you've got plenty of room to get up. So, and if you can do it in one stage, but of course, if you're not sure, it's absolutely better to do it in 2 stages.
So Brett, you're going to get a CT scan presumably for your PSI anyway, right?
And also we have a virtual modelling system for revision ACLs with the same setup. So it's very interesting when you try and get an idea of where those tunnels are and their exact dimensions in 3 dimensions based off 2-dimensional films. It's not very useful. And so we model it in 3 dimensions and map where the tunnels should be and where the current ones are. And it serves 2 purposes. One, it advises us. It actually changes the discussion with the patient. Because you've got this red tunnel, this is your existing tunnel. And here's the green one, which is the ideal one where we'd want it to be. And they can see whether it's too big, malplaced. The concept's very easy to explain. So we've been doing that now for the last year or 2, and that's what I would do. So that involves a CT scan, yes.
Perfect. Push on.
It's the pivot which is also very important here. So I think we need to add a LET as well as a revision ACL. He might also need a medial meniscus allograft, either in the same stage or future.
Okay,
I think
so
doing 8 things in one go is quite difficult. So a 2-stage approach, just closing the osteotomy in the beginning and coming back later for a revision ACL plus LET would be a better option. Plus minus a meniscal transplant in future.
So tell me why you would add in a meniscus transplant.
Because his medial side doesn't look that bad. So, and of course, if he was even slight varus, we could have done a small osteotomy to correct it to valgus a bit. That's indeed a tempting thing, just to bring him, when you're doing a closing wedge, just bring him slight valgus. It's not well tolerated generally in young people.
And also maybe he's got post-meniscectomy pain, so you're going to treat that.
Yeah. So a lot of things going on clearly with this case, very challenging, and we're going to have a conversation with the patient and see what his tolerance would be for a 2-stage versus a 1-stage. And so he really didn't want a two-stage procedure. Sorry, Brett, you're going to ask?
I just want to ask a question, actually.
Sure.
Just say he was already hyperextending 5 degrees. This is a persistent question. You know, he's easy because he's got a bit of flexion contracture, probably because he's arthritic. But we're this balance between the need to make them less likely to re-injure with correcting slope versus the increased risk of hypermobility. I still don't know. I don't know what to do. I'd love to know.
They often tighten up a bit.
Yeah,
Well, that's what everyone says, right? They'll tighten up, it'll be fine. Put them in extension, don't let them.
So I remember asking the same question to a very prominent surgeon, and he said we do controlled arthropibrosis. So
Okay.
we do controlled arthropibrosis, and we expect the posterior capsule to tighten up a bit.
So you spit in the wound and give them a septic arthritis. That'll sort it out, yeah.
Chanji, what are your thoughts on hyperextension after a slope-reducing osteotomy?
No experience in that.
No experience, yeah. It's very challenging. You know, in the Middle East, actually, we have a lot of patients who have got hyperlaxity. They've got increased slopes. And so what we'll often do, if we get to a level of greater than 10 degrees of hyperextension, we'll do a posteromedial capsular plication. But now you're adding even more surgery into the mix. So thankfully, we didn't need to do it with this case. And really, you know, I wanted to go through, I think we've gone through all of this, so any more imaging, CT, absolutely. Do you address the slope? I think all of us are probably in agreement that we're going to do something with the slope. A meniscus transplant, not a bad option by the sounds of things.
Especially it was pretty loose, wasn't it?
Right, okay, single stage or two stage, well, I think it really comes down to surgeon and patient preference. Graft options, Clement, what graft would you use?
I would use a BTB from the opposite knee.
Okay. So it was asked this morning, I mean, I've done a number of these with using BTB for ipsilateral. I have fractured the tibial tuberosity once, though, so you have to be very careful. And as Rugby said, if you're rolling the slope down, rotating that fragment, it will hit the tibial tuberosity, so you've got to make a V-shaped osteotomy behind the tibial tuberosity. You've got to have space to accept that. And in the case where I didn't get that right, I fractured, because you have two prongs of bone, basically.
Absolutely. You've got these two little tines of bone. I've done it a bunch of times, and it's probably the most nervous I ever am when doing an osteotomy. So we did a lateral tenodesis. We did a lateral meniscus root repair.
I don't know if anyone mentioned it, but with your root repair, do you make a separate tunnel, or you just drag it into the tibial tunnel of the ACL?
No, I always make a separate tunnel. And you know, it's sometimes it's an attractive option, right, to bring it into your ACL tunnel. But the problem is it's completely non-anatomic. And you know, in an ideal world, that posterior root is often coming much further forward, but our tears of our lateral roots are often more posterior. And so if you try and bring it forward into its anatomic position, you're going to overjuice the lateral meniscus, and I worry you're just going to pull through.
Yeah,
So,
anyway, we can argue about that.
I've never seen it look good.
No.
I've been tempted just to, I'll quickly pull it down, but it just doesn't.
Peter Myers taught me that, and you have to make a bit of a groove between the anatomic site and the tunnel. It's only a few millimeters, but you've got to make sure your tapes orientate into that groove.
Yeah. So we did inside-out femoral tunnel, okay, BTB allograft, bit of an older guy. We did do a meniscus allograft, slope-reducing osteotomy, and exactly the way that Rags had showed earlier on with the staples and a biplane cut supratubical. Lateral meniscus went in. And then this is an interesting one. Again, another trick that you can use when dealing with a tibial tunnel is just do a laterally based tibial tunnel and using the same aperture, but that was certainly an option. That was the lateral meniscus. I just want to shoot through because there's more things that I want to discuss with some other cases.
I'll just add, I think that's an underutilized technique in the outside in drilling, and because you've got two issues with a tunnel. One's its aperture and one's its trajectory. There's a heck of a lot of good bone. So if you're trying to get away with a one-stage revision, which I often try to do as well, you can direct the tunnel anywhere you want if you're drilling outside in. The bit that heals at the aperture and then acts as your kinematic ACL is right there, but you've got a lot of bone to pick from.
And if you use a crown reamer, you can actually get a bone dowel from drilling the tunnel.
Okay, so slightly different. This is my confession now. 23-year-old female. I did a ACL, PCL posterolateral corner reconstruction, which unfortunately failed, and I revised it, and it failed again. So she presents with a hyperextension thrust with a fairly flat tibial slope. Okay, so not a significant tibial slope when she hyperextends. Neutral coronal alignment. Now, I felt that my reconstruction was okay. My tunnels looked good. Initially I used a mixture of autograft and allograft. The revisions I used allograft, but she still failed again. So Bushnan, so in this scenario, do we do another soft tissue reconstruction, or do we try and address something with her bone, look at her bony morphology?
It's failed twice. It's saying there's something else wrong inside. The slope is quite flat. If you increase the slope a bit, that will stabilize your PCL significantly. That will also help with the hyperextension. So it might be a good option to start thinking on that line.
So if you're going to do a slope increasing osteotomy, can you maybe just briefly talk us through what technique you would use?
So exactly the way you saw just now, the only variation I do is I lift the tibial tubercle up, and then you have a plain flat surface to do your osteotomy. I do a opening wedge anterior osteotomy with allograft bone wedge in the front. It works really well. You can just reattach the patella where you want, and if there is any existing patellofemoral OA, you can even anteriorize it or proximalize it, so you can play with the patellar biomechanics as well. Not too much, just to adjust for any patellofemoral OA changes.
And what fixation are you using?
So if you got good bone quality, you can just rely on the biological plate principle. So if you have a nice 4 or 5 centimeter tibial tubercle sleeve, then you can use that as a plate anteriorly, and that usually suffices. If you want, you can add a Tomofix plate or any kind of plate on the medial side, or you can put a couple of staples on. Don't recommend staples because they crush the allograft, but it's better to put either a plate or just biological plate.
Andy?
With the abnormal slope, and a classic would be with a malunited proximal tibial fracture, you can get pseudo-laxity of the PCL. So do you think you were being harsh on yourself? And do you think once you corrected the slope, suddenly it tightened up?
There's no question that it actually, well, you know, I always find, does it really tighten up the PCL, or are you just now just in a position where you've got a more kinematically improved position, and you've got the plateaus now sort of buttressing against the femur? So for sure, you know, I think it really helps. I mean, Dinshaw, would you, anything different to what Bushnan said?
No, but if I'm doing an opening wedge anteriorly, I'm going to just check if I can avoid doing a tibial tuberosity osteotomy. So if I can avoid that, there's enough space there, I'm going to put a plate fixation there, I'm going to avoid that, because that just adds to one more osteotomy, one more healing. You know, rehab is different. So if I can avoid that, that would be great. If I can't avoid that, only then would I do that.
Subtubercle osteotomy has got a bad name when you're doing coronal plane corrections for osteoarthritis, because the bone quality is poor, you don't heal. But this isn't the coronal plane. You're going into cancellous bone. So actually, I tend to just go right as close as I dare to the tendon, but just beneath it.
Right. Okay. So, but then well, the beauty about the TTO, what I love about the TTO as well, is it actually gives you the biological plate fixation. So I think that's an added bonus, and then you are in cancellous bone.
So I always use Tomofix.
Like you're seeing at this meeting, lots of different techniques available. You know, it's really the principle of addressing the bony morphology as opposed to chasing after another slope. Now, I'm not brave enough just to leave it with the TTO, so I did put a plate on just to give it a little bit of extra fixation. So that was her 6 months post-op. Got rid of her hyperextension thrust, and she was happy. Didn't need to do any further reconstructions.
She's now subluxed anteriorly.
Pardon?
She's now subluxed anteriorly.
She's happy.
Alan, can I ask?
She won't come back for more, will she?
What was the definition of failure in this case? Was she really unstable? What was the complaints?
So she was complaining of instability and a hyperextension thrust. So it was really the recurvatum that she really didn't like. Yeah. So I'm going to buzz on through, because I'm going to come, we've got 7 minutes.
Thank God you left that one.
I've got a special case to talk about, because we talked about it a little bit earlier on. Okay. So this guy's very challenging problem. So 43-year-old male, BMI of 24, he's healthy. He's a migrant worker from Jamaica working in southern Ontario on a tobacco farm. And unfortunately, 3 months after an injury on the tobacco farm, where a truck reversed into him, causing essentially a valgus load, and he ended up with a knee dislocation. And so just to summarize this, he's in significant varus alignment. He's got an ACL, PCL, posterolateral corner, neurovascularly intact. His radiographs, prior to this injury, he had some medial discomfort, he had some pain. You can see on his radiographs that he's got some early degenerative changes on that AP view. And he has this alignment where the weight-bearing axis is not even in the joint at all. So, Chiranjeet, how do I deal with this? 3 months after a knee dislocation, KD3L in varus.
Okay, so looking at the Mikulicz shrine, which is running far away medial to the bone, I think you're looking at probably a double osteotomy in this patient to correct that amount of varus. And then after doing that, we will have to look at the ligaments as well, whether we can do at the same stage. I have no experience doing that in the same stage, post double osteotomy and all the ligaments as well.
Okay, so you're using that sort of general rule of thumb. I think it's a very nice rule of thumb just to, if you see that the weight-bearing line is not within the joint, be thinking about maybe a 2-level correction, right? I think, would you agree with that, Andy?
Yeah, although he's got pretty marked varus deformity of his proximal tibia, so you've got to measure it up and see, because you know, once you've corrected that, suddenly it all may come good. And you're aiming here not to overcorrect, you're aiming to get the weight-bearing line in the middle of the knee. So I don't know, I would need to measure it, but I wouldn't rule out just doing a tibial osteotomy.
So his MRI just shows he's got some medial meniscus deficiency and some early arthrosis. So he's also got some medial compartment issues, medial overload. This is his EUA, significant posterolateral. He's got an endpoint to his PCL, but significant laxity, and then the coronal plane laxity. So that's a summary. So Andy, I've given you these measurements, and actually I've planned out a medial opening wedge HTO for you.
Yep.
Now,
first question is there any lateral compartment opening on stance?
Actually, when you in stance on his radiographic views, there was no side-to-side difference.
When he walks, has he got a thrust?
Yes.
Okay. So the implication is that some of his deformity may be from LCL slack.
Yeah.
And the minute you get the weight-bearing line to the middle, that disappears from the equation. And so you can be very, very careful. We need to talk about convergence angle and lateral opening. If you don't take some of the correction off to compensate for that, you'll grossly overcorrect.
So I've planned out a medial opening wedge HTO here,
Yep.
and his MPTA. Oops.
Is his medial side okay?
He's got medial disease. He's got medial. So in terms of ligaments,
Yes.
ligaments are good. So his medial side is stable, but he has medial meniscus deficiency.
Yeah, but his medial
chondrosis.
ligaments are okay.
Correct. Yes.
Question for Al, it's interesting, his leg length, his pelvis looks like it's tilted. It looks like he's got a long right lower limb. Maybe I'm wrong.
He's not weight bearing properly.
Okay.
Right. So another challenge. He's very uncomfortable on that side.
Okay.
So he's got. Is this a problem, Clement? If I do a medial opening wedge HTO, I increase his joint line obliquity to 93 degrees, to then come back to do his ACL, PCL, posterolateral corner. Does that play a role? Does that play a role in our decision making? Is that a concern with maybe increasing some shear forces across the joint? Is that going to make our reconstruction more difficult? Anybody?
So, I think for any disease, you always go for bony first and then soft tissue later. If your Mikulicz line is way inside the joint or missing the joint, I think the primary goal is to get the weight-bearing axis normalized. I agree the right side also looks equally bad, and that also might need to be addressed further. But we are concentrating on the left side, so we need to get the Mikulicz line in the middle and then do a ACL, PCL as a single stage later. Once you bring him to neutral or slight valgus, the LCL will cease to be a problem as an instability, in my opinion.
Okay, Dinshaw?
I'll tell you, before we had all these fancy plates, we used to do this always as a two-step. And if you've got an ACL, PCL, LCL gone, these patients always came back for a ligament reconstruction subsequently, even after getting that alignment correct.
Al, was that your question? What was your question?
So my question is, there's no question this guy's going to need a ligament reconstruction.
Absolutely.
Okay. Now, if I change the joint line obliquity even slightly, is that going to have any implication on the future ligament reconstruction?
This is coronal plane joint line obliquity, not talking about sagittal.
Yeah, coronal plane joint line obliquity. That's where I'm thinking.
Yeah.
And then to make it a little bit more challenging, and it's a good thing for us to discuss, this guy's a smoker.
Yep.
He's an immigrant worker, and he wants to get back home to Jamaica as quickly as possible. So he wants his second stage as quickly as he possibly can get it. So Andy, I'm going to put you on the spot. Let's say you do your medial. Would you do a medial opening wedge here?
Depending on the leg lengths, basically. And I'm just worried that the pelvis was twisted, but as you say, I don't think he's straight, is he? I think it's the easiest operation. His PCL laxity is pretty gross, and I don't, in my hands, I find it really hard to keep the sagittal plane slope the same. I have to open the back twice as much as the front, and so there's a real risk you'll increase the slope doing an opening wedge osteotomy. I like doing lateral closing wedge osteotomies, and they heal more quickly. He wants to get his operation done, and often with a closing wedge osteotomy, you can do all of the surgery at the same time. So you can do one stage bicruciate lateral with a lateral closing wedge osteotomy, and next thing is you'll say, what do you do with the fibula? I leave the tib-fib joint intact, and I'm making a oblique osteotomy. I lift the nerve off it, make the osteotomy, get the right size, and close it. So I have to say, he'd be a guy, he's high risk, he's smoking. I go lateral closing wedge osteotomy as long as the limb's not short. I do a bicruciate lateral in one operation. That's showing off.
Oh, there you go. Okay, so there's a lot of things to think about here, a lot of concerns. And so my concern about doing an opening wedge was really just the timing of when I would come back to do the second stage. I agree, I can't do my ligament reconstructions with an opening wedge. With a lateral closing wedge, a little bit easier. And also, he's got significant posterolateral rotatory laxity. I do like to do a full posterolateral corner reconstruction with a tibial tunnel, and of course I can't do that if I do a medial opening wedge. So did the planning, and I actually worked out a double level correction, and we're just going to finish up on this. By doing a double level correction, you can make the correction smaller on either side of the joint. We went with closing wedges to really get early healing, and so that means I could take him back at about 3 months, take the plates out. I left him, just got him to about neutral. He's opening up still a little bit on the lateral side, hence why he's still looking a little varus. And then second stage, did a full ligament reconstruction, and now his bones look like Swiss cheese, but he has actually done very well from a knee stability. The interesting challenging point now is he's got a straight leg on one side, he's varus on the other, he's got a complete leg length discrepancy just because of his alignment. He still wants to go home, but we probably need to do it on the same side, the other side.
Lateral closing, yeah.
Anyway, I think we've done enough. So on that, thank you very much to the panel.